Welcome to the Sunday special on Top Med Talk. It's a potpourri of our favourite longer pieces, ideal for downloading and enjoying when you have a little bit more time. Top Med Talk. Top Med Talk. I'm here with Dr. Geoff Lacey. Hi, Geoff. How are you?
I'm very good, Monty. Thanks.
Colleagues from the UK and Dr. Sol Aronson from Duke University Medical Centre. Hi, Sol. How are you?
Good, thank you, Monty.
And delighted to be joined by Dr. Liam Brennan, who's the President of the Royal College of Anaesthetists in the UK, our overall leader. I would say spiritual leader, but you know what I mean, Liam. So welcome. How are you?
Monty, it's great to be here in Boston.
So I wanted to take us back, Sol, to that discussion we were having in the last podcast about the extended role of the anaesthesiologist and the perioperative medicine, perioperative surgical home, pushing out into these various places, and bring you back to that idea that we seem to be population health, public health doctors as well, and whether that's right and proper and whether we should just get back in the OR and get on with the job that we know.
Yeah, no, thank you for that slow-hanging curveball to really knock that one out of the park. I think it's really important that we do re-identify who we are as members of the healthcare team, particularly in the context of population health, and I don't think it's a stretch at all. On the contrary, I think it's exactly where we need to reorient ourselves within that continuum. Interestingly, Mark McQuillan and I just wrote an editorial that I just finished reading the proofs on, so it should be in press in the near future. Spoke to that concept in the setting of health from birth to death. Obviously, is a very long continuum, and within that very long continuum, perioperative medicine represents a disproportionately small part of that cycle. But on the other hand, interestingly, we both agree that it represents a disproportionately high opportunity to impact value. The cost of health care, once one has to confront the need for surgery, in the broadest scalable sense of that definition, is disproportionately very high. And so as specialists in perioperative medicine, our ability to impact the value proposition is really quite great. And compared to our colleagues in the other primary care specialists and or specialists, I think we shouldn't shy away from that, but embrace that. And I think it really is upon us to represent population health in that context.
Okay, so Liam, from the UK perspective, how do you think that would go down in the United Kingdom?
So I think that already is going down well, Monty. I think we have already started work through the Royal College in the UK, working with our colleagues in public health medicine, the Faculty of Public Health. I met with the president of that organisation, John Middleton, very recently, and we discussed just this: the potential for anaesthesiologists to work with our patients at a very receptive point in their health requirements when they're going to require surgery, when we can discuss their lifestyle choices, particularly around smoking, alcohol consumption, obesity, and to say, it's in your best interest now to think about how we can alter those behaviours and be part of that team working with our colleagues in other branches of medicine, surgery, and in the medical specialties to help our patients improve their general health for the benefit of themselves and for the wider community.
So how do we, from your perspective in the UK, we'll get the US perspective in a moment, and then we'll ask somebody who's going to be subjected to this job, who's going to pay for that, and where do we get the manpower from? Because we're already stretched in the operating room. So
this is part of the work that we are doing working with the political leadership in the UK for them to value and to understand the potential for anesthesiologists to work with patients, to pay for that time within the tariff system we have in the UK, to commission services, to include anaesthesia provider time to work with patients in the preoperative period and not just what we traditionally do in the operating room.
And is it more of a leadership role or a doing role, or a combination of the two?
I think it's definitely a combination of the two, Monty. I think it's changing hearts and minds, both for political leadership and for our patients.
The way we've approached this at Duke and the way we're trying to spread, if you will, that model, partly through the Evidence-Based Perioperative Medicine USA program that we're putting forward, as well as just locally, is I think it's a new care model where we have to be and should be more reliant on extenders to enhance our abilities as physicians to take advantage of those teachable moments. I think the point of transition to care is a terminology that we use often in the States. And I think the other thing that's really interesting and important to recognize is many patients that have to confront the reality of surgery being in their near future have heretofore not really been connected to the healthcare system. And the first opportunity they have, that first touch point, if you will, into their health care is because of the confrontation of having to address their surgical need. And our ability to speak wisely and effectively to that teachable moment is really, really critical as perioperative specialists.
So Geoff, keep going back to this, you're on that cusp between fellow and becoming an attending consultant. Is this what you signed up for?
Well, it wasn't at the time that I signed up for anaesthesia, but it is certainly something that I want to and excited to be involved with now. I mean, you're talking to the converted here, but we've said this time and time again, but there is such a need for good patient care for perioperative medicine, and we are, as anaesthetists, best placed to deliver that. And if we don't step up to the mark, then someone else will. And I think we can use our expertise to really make a big impact in patient outcome, and that's extremely exciting. And therefore, I'm not. There's a degree of trepidation, I suppose. There's an unknown in some respect, but I'm extremely excited at the foremost, more than anything else.
So here's a quick chance to have a chat with your president about what the future between the two of you. Have a little.
So maybe I could say I don't think we can just expect people just to do that. We've got to change our training structures, and I think this is a really great opportunity. We're about to embark on rewriting the anaesthesia curriculum in the UK. And that work has just started, and I think undoubtedly perioperative medicine, the training in it, not just from the knowledge base, but exactly how you communicate this with patients and with healthcare management in general, and lead in this respect is going to be part of that curricular review, and I'm sure that we will need to address those needs in the work that we're doing at the moment.
And it's an ability to orchestrate with our specialist colleagues in other specialties, isn't it? Because it can seem, I think, the thought that I now need to become an expert in public health and in internal medicine, etc., but it's just using your skill set as an anaesthetist with the expertise of other colleagues in other specialties to provide that overall complete care in the perioperative period.
I completely agree. I think that we've got to get away from the silo working, that this is the surgeon's role, this is the anaesthesiologist's role, this is the physician's role. We all have to be there to provide the team that in its whole is going to provide the best possible care for patients.
I think that is a commonality across both of our, if you will, domains, and certainly in the States and through the Society and American Society of Anesthesiologists. There's a very acute appreciation of the need to evolve quickly, to change our curriculum, to really introduce these concepts that we've been in an ethereal way talking about probably for decades, but to really do it in a very meaningful way. There are many fellowships that have evolved in the recent years for perioperative medicine, and I think baking this right into our residency program is really critical as well. The time, however, is yesterday, not tomorrow, to do this, and so we're having to confront the reality of fighting a battle without an army, and so I think the need to do this post-haste is really upon us. That said, I do have encouragement that there's a lot of very talented, smart, if you will, junior faculty, fellows, and residents who are embracing this idea. So I believe we will meet this challenge from an educational standpoint with great gusto.
And the grandfathering challenge, those of us who are later in our careers, does anyone have a plan for helping us to join in?
So I think that there will be those who don't want to get into this space, but I think that's okay. I think people will be encouraged to play to their strengths. There will be plenty of opportunities for those to continue to do what they do extremely well, and for others to be given the time and the opportunities within their job plan each week, each month, to work with this different spectrum of practice. It's not any, for many, I reassure them, it's not different from what they're doing already. It's just putting a structure around it. And encouraging them to do it, and actually for it to be rewarded and reflected in their weekly commitment to the anaesthesia service.
And we've seen this before. This isn't the first time we've been to this rodeo. We've evolved as a specialty to adapt to the needs to address the pain, issues of healthcare. We've adapted ourselves to address the critical care issues of healthcare. And I think perioperative medicine in a formal sense is another horizon that we're going to be adjusting and adapting to.
Is this a global phenomenon? Liam, in your position, you would have travelled much of the world representing our country. Have you seen...
even in my 24 hours I've been here in Boston, I've met with people today from Australia, from Canada, having exactly the same conversations and well beyond, certainly here in the US. So I think that this is a conversation that is happening around the world as we speak. I think seeing that the development of the specialty lies well beyond the technical. It is getting into this wider physicianly space.
Given that, we've mentioned a few times today about the various different phrases and terminologies that come up with all the same objectives. Do you think maybe changing nomenclature so that it fits across international borders will actually create a more of a cohesive bond and get that movement up and going at a greater pace than it is at the moment?
I'm sure at such an early stage in the process there's a fantastic opportunity to do that, and I think there are people that we're talking with Sol and with others that we're doing for the international EBPOM group, Perioperative Medicine group. I think there's a real willingness to build just that, as you're asking, Gus.
Any major problems you see? Where are the curveballs? Is a curveball difficult to hit or easy to hit?
It depends on whether you're a Chicago Cub or a New York Yankee, I guess. The principles are sound and solid and easily translatable. I think that universal reality is that we all, regardless of our country or zip code or region, have to confront the external tensions of a limited resource, and we're all having to address those transformative realities in healthcare. The curveball, if you will, is that everybody has their institutional bias, everybody has their own unique culture for adapting to these sort of high-level principles, but that's okay. Round pegs are not supposed to accommodate square holes or whatever the expression is, and I think we have to be somewhat flexible to adjust to the regional nuance, but the principles will withstand.
I'm sure that's right, and I think if we don't build that future for the specialty across the world, we'll stagnate and we'll be left behind. And I think you've said it, Joff, already. Other people will occupy that space. It will be other people telling us how to deliver anaesthesia and when to deliver it. We don't want to be there. We want to be doing that not just for to drive our own destiny, but to do the right thing for patients.
And medical students, can I touch on that? Because you need to grab them young, and for them to see that this wonderful career as a doctor of being an anaesthesiologist is a holistic physician as well.
Can I start with that one?
Absolutely.
I'm really keen to say something about that. So we've had no clear direction from the undergraduate offering for anaesthesia within the UK. I'm pleased to say that the UK, our Royal College is about to announce a framework for undergraduate training that is going to be launched at the middle of November. Along with that, we're going to have student and foundation doctor, resident, junior resident doctor membership categories for the college, which will draw people in to get involved and interested in the specialty at an early stage. So we get the brightest and the best going into the specialty. That's what we're keen to do.
Brilliant. Because I think the traditional career as an anaesthesiologist is a fantastic career.
Sure.
But where you are on that spectrum of the acute provision in the operating room through to being the physician providing some of those services outside of it, just seems like a really cool space to me if I was starting all over again.
Really cool space. There's the whole pre-hospital emergency medicine type space to be involved with, obviously intensive care. There's something there for everybody, but even for those who don't want to be anaesthesiologists in the longer term, there are fantastic learning opportunities within anaesthesia and perioperative medicine at undergraduate level that will equip people to be better doctors.
So let's close the last few minutes on that little bit. Perioperative medicine's not just about anaesthesia providers, is
sure,
it?
Absolutely.
So I like to use the word perioperative care, and I pinch myself every now and then to remind myself to use the word care instead of medicine, but I think it's a really good point. There are many providers that are going to stand up and help us deliver this concept that we've been talking about in perioperative care, and I think a very key and important role and responsibility of the anesthesiologist, or if you will, anaesthetist, depending on what side of that pond you sit on, is to be able to manage and to direct and to drive hypotheses for changing process for that extended care team.
Great. Well, we'll take a break now. We'll look forward to talking to you again soon. Thank you very much.
Thank you.
Great.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.